complications is immune checkpoint inhibitors, understand its underlying mechanism of action and management of its complications, and very briefly describe the newer chimeric antigen receptor T cell therapy, its expected neurological complications, and its management. So looking at the advances of immunotherapy in cancer, looking at the timeline, we can see that starting from the 1980s, we have been using different immunotherapy modulations in different cancer therapies. For example, initially it was all interleukins and interferons. And by 2000, you can see ipilimumab and nivolumab. So these are immune checkpoint inhibitors. They were discovered, and then over the next few years, they were enrolled in clinical trials. And the first FDA-approved immune checkpoint inhibitor comes in 2011, which was the ipilimumab. And then in the next 10 years, we have seen at least 7 or 8 new agents coming in, which has been FDA approved and commonly used in clinical practices. The immune checkpoint inhibitors revolutionized the world of cancer. It changed the therapeutics of several tumors and also changed the course of its prognosis. However, the mechanism of action is not limited just to the tumor cells, and hence we see a very wide spectrum of side effects. And these are commonly being referred now to as the immune-related adverse events, and we see in about 65% exposed to immune checkpoint inhibitors. And neurologic toxicities are seen in about 1 to 6%. This is from the data that we have so far. But also it's important to know that we don't have a clear data as of now, even though it's all from lots of case reports and case series. And most of these have been, and the studies and reviews that has been published are from single centers. There has been no large center, large case reports or literature review that has been come out in the last 10 years. And the diagnosis and management remains to be challenging in many situations, especially with the concurrent other systemic side effects, and also lack of knowledge about these adverse events, and misclassification and underdiagnosis also. So the agents that we would be talking about, and that is in practice these days, are mainly the anti-CTLA-4, as I talked about, the ipilimumab, which was the first FDA-approved drug in 2011, and followed by the anti-programmed cell death ligand-1 and the programmed cell death 1 antibodies, and these are the other immunotherapeutic agents that we commonly most of us are very familiar with pembrolizumab and nivolumab. We commonly refer to its brand names, pembrolizumab, which is the Keytruda, and nivolumab, which is the Opdivo. And these, in either in monotherapy or in combination, we have seen so many times. So coming to its mechanism of action, so there are two main interactions that control T cell activation. So one is the binding of the CTLA-4 or the cytotoxic lymphocyte antigen protein 4 on the T cells, which bind with the CD80 or 86, also called the B7-1 or B7-2 on antigen-presenting cells. And the other one is the programmed cell death receptor 1 binding to its ligand PDL1, or the programmed cell death ligand 2, or the PDL2. So these mechanisms usually keep the T cells in check, but With the immune checkpoint inhibitors, these are monoclonal antibodies that would block these inhibitory pathways and allowing for the T cells to become hyperactivated and get a greater immune response, which would act against humans. So, as far as therapy for cancer, this was a great discovery that we had. So, this is just the image. Again, we can see the CTLA4 on the inactive T cell, which usually binds with the B7-1 or B7-2 receptors on the tumor-presenting antigen T cell. So by blocking these are the immune checkpoint inhibitors, which would bind to the CTLA4 receptors on the T cell, thereby promoting the activated T cell, which would then kill the tumor cells, leading to tumor cells. And this is, again, reviewing the anti-PD-1 and PD-L1 receptors. And these are the different agents. As we talked about on the anti-CTLA4, we have the ipilimumab and tremelimumab. And on the PD-L1 and or PD-1 receptors, we have the nivolumab, pembrolizumab, atezolizumab, durvalumab. These are the commonly used agents. So it's basically like you are taking the brakes off the immune system and your immune system is hyperactivated. So what happens when you take the brakes off? So the blockade of CTLA4 and PD-1 or PD-L1 interactions have been replicated in animal models, and they have been found to facilitate autoimmunity. And we also have several hypotheses in this, but the exact mechanism is not clearly understood. There are also hypotheses about the regulatory T cells, which are key players in maintaining the immune tolerance, which can also express CTLA4 and PD-1 direct targets. Other hypothesis that we have is immune checkpoint inhibitors have variable effect on cytokines, and we can have pro-inflammatory cytokines, which can lead to destruction, whereas anti-inflammatory cytokines, which can help maintain immune tolerance. And cytokines have been studied as potential prognostic markers in certain patients with immune checkpoint inhibitors in certain studies. And we also have seen certain pro-inflammatory cytokines, like the ones that I have mentioned here, in severe immune-related adverse events in a study of melanoma patients. And also the elevated expression of interleukin-17 has been associated with immune-related neuroendocrine toxicity. And again, molecular mimicry, as in other autoimmune conditions that we know, has also been hypothesized. For example, there are shared epitopes between myelin and melanocytes, as they both originate from the neural crest. So if there is a common mutation in the melanoma and it's related to the NMDA receptor, and hence creating anti-NMDA antibodies. So that is one hypothesis that we have. Epitope spreading, which means that release of tumor and non-tumor antigens might facilitate new immune responses, which can trigger autoimmunity. And again, paraneoplastic neurological syndromes, we have found them to be worsened, or we find it more revealed when immune checkpoint inhibitors are used. This has been established in certain studies by demonstration of the antibodies in pre-treatment blood samples, suggesting that these patients may have these pre-existing antibodies and are at an increased risk for developing these complications when they are put on immune checkpoint inhibitors. And other genetic factors like polymorphisms of CTLA4 antigen and gut microbiome. So these are all the various etiological factors or pathophysiological mechanisms that we know so far, but nothing has been clearly established. And this is just in brief, in picturization of what we just discussed about the role of individual genetics, the gut microbiome, individual characteristics, if there are any genetic polymorphisms, and if the activated T cells are promoting pro-inflammatory cytokines, epitope spreading. So these are all the possible mechanisms underlying the adverse events. Now, coming to immune-related adverse events, most commonly it affects skin, the gut, endocrine system, and the lungs. And we see that more in combination immune therapy with the programmed cell death 1 plus the CTLA4 blockade. And they are expected to see the higher grade, which is the grade 3 to grade 4 severity of the immune-related adverse events. And these can happen anytime during the course of treatment or even after the discontinuation. However, the most severe events, we see it immediately in the weeks or days after the treatment initiation. So this is in brief. I just mentioned the title as all the itis. As you can see, it can affect almost every organ in your body, every system, almost every complication that you can think of. So I wouldn't be going into detail about this, but we will talk in detail about the neurological immune-related adverse events. And recently, we have come up with the grading of severity of the immune-related adverse events, which is graded from grade 1 to 5 based on the severity with mild, moderate, severe, life-threatening, or death-related to adverse. And grading helps us in deciding whether the treatment needs to be continued or discontinued, or whether it can be reintroduced if a grade 3 or grade 2 symptoms resolve to a grade 0 with no symptoms, which we'll discuss in the next coming slides. So again, coming to neurological complications, it can affect both peripheral and nervous system and central nervous system. Interestingly, peripheral nervous system has been noted to be twice as more affected than central nervous system. With the peripheral nervous system complications, we would see myositis and myasthenia gravis, which is the most commonly seen complication, followed by peripheral neuropathy, Guillain-Barré syndrome. And central nervous system, the manifestations are very diverse. It can be encephalitis, aseptic meningitis, CRESS, demyelinating lesions, or also the revealing of the paraneoplastic neurological syndrome. So, and a single neurological immune-related adverse event mostly happens, but there are cases that has been reported where patients develop 2 or more neurological immune-related adverse events at the same time. And it's very important to note that these are frequently associated with other systemic toxicities. So you might see patients with thyroiditis, colitis, hepatitis, along with the patients that we are seeing for neurological complications. And this could be a clue alerting us that what we are seeing could be related to the immune checkpoint inhibitors. So we'll discuss about a few cases here. These are some of the interesting cases that I have seen over the last 3 years here. So coming to our first case, so he was referred to the ER from his routine oncology outpatient visit for an urgent neurology consult. He's a 73-year-old male. He's a Jehovah's Witness with undifferentiated pleomorphic sarcoma. He has a lesion in his left inguinal area, and he presents with drooping of eyelids bilaterally and blurry vision of 5 days duration. And he also endorses some mild shortness of breath of 3 days duration. And these symptoms started 2 days after his second dose of pembrolizumab. So this case is a little bit different, especially with the religious concerns that immune checkpoint inhibitor was used as his first line, as the other traditional chemotherapeutic agents make him more susceptible to blood transfusions, given the risk of bone marrow suppression. And on exam, this patient had bilateral ptosis. The right side was a little bit worse than the left, and his eyelids were gaped up, and he had this hypophonic speech. But rest of his other neurological exam was so we did an initial workup. His CK level was found to be high. It was in we checked for myasthenia antibodies and myositis antibodies. The results came back later on. But based on the clinical suspicion, we, and also along with our discussions from our oncology colleagues, was worried about if this is a myasthenic syndrome related to immune checkpoint inhibitors. He was started on pyridostigmine and also high-dose steroids. With the pyridostigmine and high-dose steroids, he did not initially show much of any improvements. He was not a candidate for IVIG given the religious reasons, but was later willing for plasma exchange, and which was started 2 days later during the course of his admission. But there were some issues with him tolerating the albumin, and he had some allergic reactions during the plasma exchange, and he was only able to tolerate 2 sessions. And we kept clinically monitoring him. There was some improvement in his symptoms. Looking at the labs, his CK was trending down, and it almost plateaued, and kind of indicating that the disease might have been in the plateau phase. So it was decided to stop the plasma exchange given his intolerance, and also pyridostigmine was also stopped given not much of any improvement with the medication, also some side effects noted. So we decided to continue oral steroids and discharged. 2 weeks later, he was seen in the outpatient clinic and his doses had resolved. And it was decided by the oncologist to continue a steroid taper dose over the next 6 to 8 weeks. And this was graded as a grade 2 severity of the immune-related adverse event. Subsequently, the pembrolizumab was stopped, and he was then referred to surgical oncology. And very recently, he had a surgical resection of the mass. I don't have details about how the patient is currently doing. So with this case in mind, we would talk about myositis and myasthenia gravis in the next coming slides, and a combination of myositis and also more frequently. And this is the most common neurologic complication that we have has been reported so far in the literature. So immune-related myositis differ from the usual idiopathic or inflammatory myopathies such as dermatomyositis and polymyositis. Compared to them, the oculomotor and axial muscle involvement are not that uncommon. We would also see other features such as dyspnea, dysarthria, and dystonia. Most common and early symptom is myalgia, even without CK elevation. And it is also important to note that the CK level has no correlation with the severity of symptoms. We have seen milder cases of myositis with a very higher CK compared to a less one. And the median interval between the administration of the medication and symptom onset that we have found from case series is about 25 days. And the shorter interval, if a combination of their immune checkpoint inhibitors like the nivolumab and ipilimumab combination, which is very commonly used in clinical practice. And we can see progressive generalized muscle weakness and respiratory or cardiac failure, which can be life-threatening. So with myositis, if there is a component, that can be potentially fatal, as that can lead to much more serious complications. And we have seen about 10 to 20% cases may require mechanical ventilation. The fatality rate has been reported about 15%, but again, with the involvement of myocardium, it can reach up to 50%. The myositis is completely resolved in about 50% in some cases, but we also see remaining sequelae in about 16%. And I saw 2 studies which showed higher mortality in patients with immune checkpoint inhibitor-related myopathies compared to our usual idiopathic or inflammatory autoimmune myopathy. And it's really important to recognize common features between immune-related myositis and myasthenia gravis, and these can happen at the same time in patients, and we see that very commonly. Because of that, we may need other diagnostic investigations like muscle biopsies, which may be helpful in distinguishing patients with myositis versus myasthenia. And again, in immune-related myositis, we see the involvement of myositis more than myasthenia. Elevated CK levels, transaminases, troponin T levels, these are other supporting factors which can help make the diagnosis. And EMGs can show myopathic motor unit potentials with positive shock absorption potentials. Imaging, again, these could be non-specific, but we can find contrast-enhanced areas. MRI may show hyperintense intramuscular alterations with contrast enhanced. But these are all supporting factors in helping making the diagnosis. Again, when we look at the muscle biopsy, necrotizing features are more frequent, and we see macrophages and T-cell infiltrates. But this is controversial and has been described in both cases, which is the immune-related and the inflammatory myopathies. And also, this has a lot of other factors like the site of biopsy, the use of steroids before biopsy. These all can lead to a high number of false negatives. So this is a picture that I have from case reports, where you can see a high number of T-cell infiltrates in the muscle. And these are the stains in which we have positive CD3, CD4, and CD8. And this is just a magnified view. Again, we can see a lot of inflammatory cells. Coming to myasthenia gravis, again, as I mentioned, concurrent myositis is frequently seen, because of which we may need to do a comprehensive labs, EMG, and if possible, muscle biopsy. And these together can increase the risk of myasthenic crisis, and we can expect to see higher mortality rates. Mostly with immune checkpoint inhibitor monotherapy, we come across myasthenia gravis, whereas we saw earlier that immune-related myositis may be combination immune checkpoint. And the median time interval to symptom onset is about 40 days. And anti-acetylcholine receptor antibodies were positive in about 80% cases, but comparatively in lower titers compared to classic myasthenia. And the diagnosis is clinical, but we also need electrodiagnostic tests. And the treatment is usually with a combination of pyridostigmine and high-dose steroids. And if no response to those, IVIG or plasma exchange are the next options. So now coming to other peripheral nervous system complications. So next one, I will talk about GBS. So the pathogenesis of GBS in or Guillain-Barré syndrome in immune checkpoint inhibitors is, again, we have a lot of reported hypotheses and mechanisms. Again, a possible molecular mimicry is a possible explanation that we have for these syndromes. And T-cell mediated autoimmunity against melanomas may affect myelin antigens and Schwann cell membrane. So this is one example where we have found molecular mimicry, and Guillain-Barré syndrome is totally possible in immune checkpoint inhibitor related. And we see a median time of onset about 38 days. But when we look at the case reports that we have so far, it's a rare complication. Incidence is counted to be about 0.1 to 0.3%. And there was a study done by Fan et al. Which looked into the FDA reporting system, where in about 76,000 case reports with immune checkpoint inhibitors, there was only 0.1%, which is about 149 cases of GBS were totally detected. And again, we have reported about 22% mortality, and 59% of patients were related to monotherapy treatments of immune checkpoint inhibitors. Again, just like how we saw in myasthenia, that monotherapy applications were seen. This is just a picture. This is not one of our patients. This is just from where we can see the post-contrast enhancement of the nerve roots. And this was a patient who presented as GBS in a malignant melanoma patient. So this is just in reviewing the common peripheral neurological syndromes. So these are mainly the Guillain-Barré syndrome and peripheral neuropathy. I did not put that in a slide, but peripheral neuropathies compared to traditional chemotherapeutic agents are very rare and less severe in the case of neuropathies that we have seen with immune checkpoint. So now we will discuss about some central nervous system complications, and this is another interesting case that I saw 2 years ago, and I think I also presented in conferences. So this is a 39-year-old female with a poorly differentiated endometrial cancer, that's post hysterectomy, radiation, and chemo, and she was then started on pembrolizumab if she failed her traditional chemotherapeutic regimen. So she presented to the ER with severe headache and vomiting a day after her second pembrolizumab. She was symptomatically managed for her headache in the ER. Just a CT head was done, which was normal. She was discharged. 2 days later, she returns to the ER with severe headache, vomiting, vision, and this time with and on exam inside, interestingly, she said that's sick, and we were also seeing cortical nystagmus. Repeat CT was done. Radiologists who compared the previous CTs, we can see this was her initial CT for her initial visit in ER, and this was from her second visit. And we can already see enlargement of the lateral ventricles in the fourth ventricle here, suggesting there would be a developing hydrocephalus, which prompted to get an MRI of her brain, and we can see involvement of her cerebellum. So, and also some post-contrast enhancement in her left cerebellar peduncle, and also have not included those pictures, but we also found some leptomeningeal enhancement. So based on this, our initial differentials were whether this is a cerebralitis related to common viral infections or paraneoplastic cerebellar degeneration, as she has an endometrial cancer, or if this is a leptomeningeal carcinomatosis, or if this is a direct toxicity from immune checkpoint inhibitors. Our LP showed mostly non-specific findings like lymphocytic phagocytosis, mildly elevated protein. No malignant cells were identified on her cytology. We sent serum and CSF paraneoplastic panel, which later on resulted as negative. But based on the clinical suspicion, we did start her on high-dose steroids, and her symptoms, her diplopia actually completely resolved in 2 days. A repeat MRI was performed 10 days later, which showed interval improvement and decreased mass effect. She was discharged later on steroid taper, and we saw her 4 weeks later. She returned to the ER with even worse symptoms, but her steroids was just stopped almost 5 days prior to her arrival in the ER this time. So again, the high-dose steroids were restarted. A repeat MRI was done, which showed persistent cerebralitis, but again, not much of mass effect, how we saw with her initial presentation. Interestingly, this admission, we also found coexisting thyroiditis in this patient. However, clinically, she was not showing much of any improvement this time. There were also complications related to the steroid use, steroid-induced psychosis, and family opted for hospice care at this point. And she passed away in 2 weeks after. So coming to after this case, I would like to discuss about the autoimmune encephalitis and paraneoplastic neurological syndromes, which can happen more commonly with the use of immune checkpoint inhibitors. And recently, we have also started receiving more consults from subspecialties asking in any altered mental status patient with the use of immune checkpoint inhibitors, if there is an autoimmune encephalitis, that's the underlying pathology here that we are dealing with. It's just like how we get lots of consults from psychiatry in patients that we are asked to give an opinion if there is an autoimmune encephalitis that is contributing to the symptoms. So the incidence is rare. It's about 0.1 to 0.2%, but it's been more increasingly reported recently. It is more common in combination therapies and more common with PD-L1 inhibitors compared to the other ICIs. And the onset of symptoms is about 2 months. An MRI can show usually hyperintense neural temporal lobes or involvement of cerebellar, as we see in the T2 or flare sequences, and we can sometimes. EEG has shown some epileptiform activity in approximately 35% patients, but there is no specific EEG pattern that we have. Again, CSF can show lymphocytic phagocytosis, elevated protein, presence of oligoclonal bands have seen in some cases, but these findings are pretty non-specific and can be seen in various other CSF findings. But one study reported that high levels of adenosine deaminase has been reported, which could be a diagnostic clue for these conditions. Commonly affected cancers are, interestingly, melanoma and cancer. And commonly detected antibodies is anti-NOD2 followed by anti-Q and other NMDA, Caspar-2, and EGFR. This is not one of our patients. This is from continuum. This is from the limbic and dancer. This was in a patient with melanoma on pembrolizumab. CNS vasculitis is also reported. Medium and large vessels are affected. The exact frequency is unclear. Clinical presentation is just like any other vasculitis. Again, CSF can show inflammatory findings like lymphocytic pleocytosis and elevated protein. And occasionally we can see an increase of interleukin-17 in the CSF, which may be helpful in discriminating primary meningitis of CNS from other ischemic disorders. MRI can show abnormal findings. Again, these are characteristic of vasculitis seen in other systemic vasculitis too. We can see microangiopathies, hemorrhage, ischemic infarctions, and other E2 abnormalities. And CTAs and PET scans are also useful to detect abnormalities. But again, brain biopsy seems to be the gold standard for definitive diagnosis. Again, if we find other positive ANA or ANCA, this can indicate that the patient may have an underlying systemic vasculitis or other rheumatological condition. Aseptic meningitis is also frequently seen, and this should be differentiated from other causes of infectious meningitis and also leptomeningeal carcinoma. Again, the incidence is fair, about less than. So this is another case which we recently saw, and this was also previously presented. So he's a 70-year-old patient with renal cell carcinoma. He was admitted for cytoreactive left-sided nephrectomy. The surgery unfortunately got canceled because the patient developed severe headache and vomiting, and the headache was not responsive to the traditional symptomatic management. And the symptoms started 2 weeks after his second infusion of nivolumab and ipilimumab. Again, on exam, he was afebrile, no meningeal signs, no disc edema, no other deficits. It was just unrelenting headache that he had. So we performed an LP on him with a normal opening pressure, non-infectious labs, cytology again negative for malignancy. Again, he was not responding to any usual symptomatic measures that we use. This was the MRI that we had. So you can see the markedly enlarged pituitary. This is the pre and post images, and also with some post-contrast enhancement. Pituitary suggesting possibility hypophysitis. Further lab workup revealed that this patient also had low pituitary hormone levels. Endocrinology team is also involved at this point. High-dose steroids were initiated, and we saw dramatic improvement in the symptoms within them. So this was graded as a grade 1 adverse event, and decision was made to continue the immunotherapy in this patient. And in the case of hypophysitis, we see it most commonly within 8 to 10 weeks, and commonly seen if in case of combination immune checkpoint inhibitor therapy, and the hormonal deficiency is usually permanent and they may require lifelong hormone supplementation. The next complications that I want to talk about is transverse myelitis. Very few cases have been reported so far. Interestingly, in many cases that has been reported, there has been underlying thoracic radiotherapy that most patients had received. Symptoms are similar to classic transverse myelitis. And this is a picture that I got from one of the case reports that have been published. You can see the involvement of the thoracic cord and logically of extensive transverse myelitis. MS and other demyelinating lesions are also frequently seen. It is interesting to note that if the patient had a radiological isolated syndrome prior to initiation of the therapy, went on to develop severe clinical manifestations after the therapy with clear, obvious imaging and clinical patterns found later on during the course of treatment. The time course is variable, but usually we see up to 1 cycle to a median of 9 cycles after the initiation. And we also find lots of MS relapse rates. This is not from any of our patients. This is again from, we can see these lesions which are contrast enhancing. You can also see the timeline prior to the initiation of therapy, there were no lesions. Cranial neuropathies are also commonly being reported. Most commonly, we see facial nerve, bilateral facial nerve. We did have a case 2 or 3 years ago, again related to a pembrolizumab, followed by vestibular, cochlear, and optic nerve neuropathies. Again, time of symptom onset could be 3 months. CSF analysis showed an inflammatory pattern, and an MRI can show a contrast enhanced affected nerve in 25%. So this is in brief about the various neurological complications that we can see with immune checkpoint inhibitors. And I know this was very extensive, and you name the condition, we see all of them. So coming to discussing about management, there are 2 main aspects that we have to consider. One is whether the therapy has to be discontinued, whether temporarily or permanently, and if other administration of immunomodulatory treatments are required. So the practice that we have seen so far is for grade 1, treatment may be continued, but in grade 2 or higher, treatment has to be discontinued. But again, in some grade 2, if the symptoms are milder and if they resolve until grade 1 or 0, reinitiation of therapy could be a consideration. And again, we have to weigh the risks and benefits of resuming the treatment against the risk of an uncontrolled malignancy that we are primarily doing. This involves discussion with oncologists, other specialists, based on the other systemic toxicities the patient might. Again, steroids are our first line treatment so far, and if once we see an improvement in steroids, we can consider a taper steroid dose. But if we don't find an improvement in steroids, other immunomodulatory therapy may be required. Coming to steroids, you can expect definitely steroid-related complications, gastritis, osteoporosis, and opportunistic infections. If we are planning for a prolonged taper therapy, definitely initiation of proton pump inhibitors, vitamin D, and calcium supplementation, and pneumocystic prophylaxis should be considered if indicated. And as I mentioned earlier, if we don't see a prompt response to steroids, IVIG or plasma exchange are the next options that we have. There has been some clinical trials and some case series that reported that other immunosuppressants such as azathioprine, mycophenolate, rituximab have been used in few cases, but we don't have great evidence yet. And again, there are no large central trials that has looked into this so far. So this has been a brief about immune checkpoint inhibitors, its complications, the underlying mechanism of action, and the management. Now, very briefly, I will discuss about the chimeric antigen receptor T cell therapy. This has been one of the most exciting recent therapies in the oncology world. And it has found great success in managing B cell malignancy, which has led to approval of two FDA agents. So now I'll talk about how the CAR T cell therapy works. So from the patient, we first extract the T cells. The T cells are then genetically modified, and their specific receptors called the chimeric antigen receptors are added, and these are then grown. And before reintroduction of these altered T cells or the genetically modified T cells, the patients are primed with chemotherapy. And then the new CAR T cells are introduced into their bloodstream, which can then bind to the cancer surface antigens, initiating killing of the malignant cells. So this is again complicated by unique toxicities related to cytokine release and other neurotoxicities. In this, it has been commonly referred to as ICANS, or immune effector cell-associated neurotoxicity. You see it in up to 40% of patients with manifestations, diverse neurological manifestations, just like how we see with immune checkpoint inhibitors, and some of them maybe. So that was in brief about the CAR T cell therapy. And again, various host and tumor factors are associated with the risk of developing complications and its severity. And the treatment is again steroids that we have used so far. Tocilizumab has been used for cytokine release syndrome complications, but however, in other neurological toxicities, it can worsen. So, so far, with this talk, with this review of immunotherapy in cancer, some important takeaways that I have is these complications are rare but very relevant and can be potentially fatal and can lead to long-term disability or death. The clinical presentation is very diverse, but we have lack of clinical trials to exactly guide the management. The early recognition and adequate treatment is important for clinical recovery and guiding and prognosis. We need better tools to predict